Yeah, good morning, everybody. Thank you so much. Thank you, Dr. Karthikeyan, for having me in this meeting. I hope my slides are visible. So, my task is to talk about stroke prevention in atrial fibrillation and CAD patients, role of direct acting oral anticoagulants over next 15 minutes or so. Now, we are talking in this in the context of the fact that atrial fibrillation is one of the leading cause of stroke. I'll not dwell much on that, but it is so important that most of the guidelines, they emphasize finding out whether the patient requires anticoagulation or not, even before we go for the rate control or the rhythm control therapy. So it's something of fundamental importance in all patients with atrial fibrillation. In fact, now we have to look for patients who do not need oral anticoagulation rather than those who need it. And coronary disease being very common, it's quite often that we have an overlap of coronary heart disease as well as atrial fibrillation requiring anticoagulation therapy. In fact, that can be in up to various studies from 5 to 20% of patients who require both therapies. And that is where the problem begins. Because we know that for stroke prevention, we have to give anticoagulants. Antiplatelet agents are not effective. While in patients who have coronary heart disease, particularly those who undergo PCI, we have to use dual antiplatelets, and that leads to a triple anticoagulant therapy, antithrombotic therapy, and which is associated with major bleeding. So that is the topic of the discussion today as to how we should approach this issue of major bleeds in patients who require antiplatelets as well as anticoagulants for prevention of stroke. And this is one of the largest studies, the Danish study, where they studied it on like more than 100,000 patients, and they found that the triple therapy is associated with 10 to 13% major bleeds per year. So that's a very significant risk of the giving a triple therapy. So there has been continued emphasis on trying to see if we can, in CAD particularly, we can either avoid antiplatelet agents completely in stable patients, or after PCI, we can reduce it to single antiplatelet agent along with the anticoagulants. And there is so much of infusion of data that there has been a continuous revision of guidelines. And this is also compounded by the fact that there are various societies, they publish their own guidelines. The ACC-AHA guidelines, European Society, Canadian Cardiovascular Society, and then we have the New Zealand, Australia Cardiovascular Society, Asia Pacific Society. So they all publish, and they don't publish together. So there's always some confusion because 1 or 2 years usually pass between the different guidelines, and they all look at the new data or relevant data in their own localities and come up with slightly different guidelines. So I'll try to synthesize them all. Now, basically, there are 3 clinical scenarios in this situation. One is patients who have PCI in AF patients who are on oral anticoagulant for stroke prevention. Second is patients who have recent ACS or PCI who develop atrial fibrillation and they require anticoagulation. And then we have chronic coronary syndrome patients who have stable angina or who have had a revascularization more than 1 year, who have AF and they require anticoagulation. So these are the 3 usual clinical scenarios. Now, recently one paper has been published, the EHRA Practical Guide on Use of NOACs, which is revised just a couple of months back, which has given a default strategy for patients after PCI. That's what I'm going to discuss first. Now, we know that for last several years, there have been guidelines that we must give triple therapy for about a month, followed by dual therapy for up to 12 months, and then monotherapy with anticoagulant. That's a fairly settled strategy, which has been further made more aggressive this year. And both the European guidelines as well as this document also suggests only 1 week of triple therapy, followed by dual therapy for 6 months to 1 year, and then monotherapy. So the 6 months thing has come up very recently. And this is basically for stable patients who don't have any acute coronary syndrome or PCI. If it is done electively in stable patients, then we can further restrict the duration of dual therapy to only 6 months, and subsequently we can continue OAC monotherapy. Of course, in certain situations, we have to further increase or intensify the combination therapy. And these are patients who have stenting of left main or proximal LAD, proximal bifurcation, patients who have had recurrent MI or stent thrombosis in the past, and also have low bleeding risk. So we can increase the duration of this combination therapy in these patients. Now, briefly to talk about the various trials which have been done for on this particular subject. The earliest was the OAC trial, which was done using warfarin and clopidogrel, which was compared against triple therapy. And they found that not only was the bleeding incidence significantly less, but they also found that there was a less chance of a composite endpoint of death, MI, and stroke and stent thrombosis. So they found that this strategy of using OAC, that was warfarin in this particular study, and clopidogrel was very good compared to a triple therapy which combined aspirin as well. And there were other trials using direct-acting oral anticoagulants like the Pioneer AF PCI, which had 3 strategies. One was rivaroxaban 15 milligram combined with the single antiplatelet, which was clopidogrel in most patients. And that was compared against 2 other triple therapy regimens. One was using rivaroxaban, very low dose, 2.5 milligram twice a day. And third was vitamin K antagonist. And they found that the bleeding incidence was significantly less in the dual strategy involving, and also in both the strategies involving rivaroxaban compared to the triple therapy involving warfarin. While the incidence of ischemic complications was not increased, but this was, we must remember, it was not powered enough because the confidence intervals are very wide. So we cannot draw any conclusive evidence from this because it wasn't powered enough. So that still remains the question in the minds of interventional cardiologists, whether ischemic complications will increase by omitting aspirin or not. There was another study, ReDual PCI, where again 2 arms used dabigatran 150 milligram twice a day along with clopidogrel in most patients. It was, I think 7% patients used ticagrelor, but mostly it was clopidogrel. And third arm used warfarin along with the P2 Y12 inhibitor and aspirin. In US patients, only dabigatran 150 milligram was used. And they also found same thing, which was quite predictable, that use of dual therapy reduced the incidence of significant bleeds and without affecting the ischemic complications. It was a composite endpoint of MI, stroke, or systemic embolism, or death, or unplanned revascularization. But if you look at the granular data, we see that there was a slight increase. There was an increase in numerical numbers of myocardial infarction and stent thrombosis with dabigatran 110 strategy. We did not reach a statistical significance, but if there is a possibility that if number of patients was high, it would have led to a more tight confidence intervals. It might have met the significance level. There was a study published after that incorporating the OAC trial, Pioneer PCI and ReDual PCI, which also suggested that the bleeding incidence was significantly reduced without much affecting the major cardiovascular events, although there was slight trend towards increase, but then definitely it wasn't a conclusive evidence. And then Augustus trial was done, which again is a comparison between it was a 2-into-2 factorial design where they compared apixaban versus warfarin, and then they were further randomized to receive aspirin or placebo. And they found that the apixaban arm had significantly less bleeding complications against warfarin. And also, if you omit aspirin, the bleeding complications were significantly reduced. So there were 4 arms. And the least bleeding was seen in the patients who received apixaban and placebo. They did not receive aspirin. So apixaban and clopidogrel in this particular study. And this was comparison of the adverse endpoint, the death or hospitalization. And we find that the apixaban was better compared to warfarin. And as for aspirin versus placebo, there was no significant difference. But again, if you look at the granular data, you find that the definite or probable stent thrombosis was higher, almost double, in patients who were not giving aspirin. So omission of aspirin led to increase in the ischemic complication that did not reach significance. So, but it was quite close to achieving significance. So this question is still not settled as to what should be done about it. There is a very recent meta-analysis which has combined all these trials, Augustus, Centra-Stay, PCI, Pioneer PCI, which again shows the same thing, that the bleeding complications are definitely reduced in patients who are given dual therapy. As far as the cardiovascular death is concerned, not much significant effect. But if you look at the myocardial infarction, there is a trend towards increase which favors triple antithrombotic therapy. And the p value did not reach significance, but was very close to achieving significance, is 0.06. So, and this is from the same, another graphic from the same meta-analysis, which shows that there is a trend towards increase in stent thrombosis and myocardial infarction with dual therapy. So look at the numbers. This is very important slide. What they have look at the required number to treat. So they say that with triple therapy, the intracranial hemorrhage is increased. So if you give dual therapy, then you say about you have to treat 300 patients to save one patient from intracranial bleed. 300 patients you have to treat with dual therapy to save one intracranial bleed. But you add one stent thrombosis and half like myocardial infarction for the same risk. The overall numbers are so small. So I think this can be left to the discretion of patient and of course physician. We can look at the patient individually. Patients who have a high bleeding risk can certainly, there's no doubt that we should use dual therapy. Patients who have very low bleeding risk, we can increase the duration of triple therapy. So this is something which has to be practiced individually, and that's what the guidelines also state, that we have to take into account both the CHAS-VASc score and the bleeding risk. The ACC HA guidelines last year, 2019 in fact, they suggested that we can use a dual therapy. And if we have to use dabigatran, we must use 150 milligram twice a day. And it's quite reasonable to reduce the risk of bleeding as compared with triple therapy. If we use rivaroxaban, we have to use 15 milligram daily along with clopidogrel, because that was the regime used in Pioneer PCI trial. If we have to use I think Augustus trial was not published by that time, so they've not included apixaban. But if triple therapy is prescribed in patients who have atrial fibrillation and who have undergone PCI with stenting, either drug-eluting or bare metal, then transition to dual therapy may be considered in 4 to 6 weeks. So that was the recommendation of the ACCHA guidelines, that we must continue triple therapy for 4 to 6 weeks. The recently published ESC guidelines are more aggressive, and they suggest that in ACS patients, we should use less than 1 week of triple therapy and 12 months of dual therapy, and then monotherapy with a direct acting oral anticoagulant. That's a class 1A indication. And but triple therapy with aspirin, clopidogrel, and OAC can be given for longer than 1 week in patients where the stent thrombosis risk outweighs the bleeding risk. So in patients which I mentioned earlier, left main thrombosis, bifurcation, left main PCI or bifurcation PCI, or patients who have a high thrombotic risk, otherwise they can be given up to 1 month of triple therapy followed by 12 months of dual therapy and then NOAC monotherapy. So individualization is recommended by ESC guidelines as well. And in patients who undergo PCI for chronic coronary syndrome, we just have to give 1 week of triple therapy, 6 months of dual therapy, and then we can go directly to NOAC monotherapy after that. And again, they have recommended that in selected patients, you might have to increase the duration of triple antithrombotic therapy. The third scenario is patients who have stable coronary disease and require oral anticoagulation for stroke prevention. And here, all the guideline committees, they agree that we don't need to give antiplatelet agents in patients who have stable CAD, who have had myocardial revascularization by PCI or CABG more than 12 months earlier. So we can just continue oral anticoagulation, preferably with the direct acting oral anticoagulants, these patients. But recently, and this was largely on very fragmented data and indirect evidence. The only randomized trial which has suggested this is the FIRE trial, which was published a couple of years back, where they took about 2,200 patients who were randomized to rivaroxaban alone versus rivaroxaban and one antiplatelet. And they found that the composite of stroke, systemic embolism, MI, unstable angina requiring revasc or death was significantly better in patients who received only rivaroxaban. And the same thing was also true for the major bleeding. So from both safety and efficacy point of view, monotherapy was found superior to dual therapy in patients with stable CAD. So friends, to conclude, AF patients undergoing PCI, we have to balance the ischemic event risk with bleeding risk. Particularly stent thrombosis has to be considered. The risk of stent thrombosis, and we have to select the optimal therapeutic strategy accordingly. Most patients who don't have a high ischemic risk will likely benefit from dual therapy, so that should be given after 1 week to 1 month of triple antithrombotic therapy. And of course, this is something which is very dynamic. So because all these trials were done on clopidogrel, and our interventional cardiologists do not like using that molecule. They like to use ticagrelor more and more. But the guidelines continue to focus on clopidogrel because that is the agent that was used in these trials. So we need to have more trials involving more potent antiplatelet agents such as ticagrelor in dual regimens. And we also have to improve risk stratification for assessment of bleeding and ischemic risk in this population. So this is a continuing effort. And I think as time passes by, we will have more data and more, better guidelines to take care of these issues. I think I'll stop here and take if there's any question. Thank you very much for listening.